resilient preparedness and sustainable service delivery. That being said, we are not wasting time. We want to move straight ahead to our first presentation this morning. And we want to hear from Dr. Serene Ning, she's the executive head of the G20 Joint Financial Health Task Force Secretariat at the WHO. And she will focus on the mandate of the JFHTF, the 2024 financial framework, and the links to national implementation, and how have they been able to support countries to achieve this. So over to Dr. Serena. You have 8 minutes, please. Thank you.
Thank you very much, Dr. Linda. So I can see the slides on the screen. Firstly, thanks very much for inviting me to speak on this event. And I'll focus the presentation on the work I've been leading in the G20 Joint Finance Health Task Force. And I'm really glad that Priya is following on, because the task force was the birthplace of the Pandemic Fund and really highlights this linkage between sort of political support and actually operationalization. So firstly, just to turn to the first slide. So okay, just on the outline. So I also wanted to touch a bit on domestic resource mobilization, and to just help sort of share a common understanding of what that is and where health is placed within that. And then talk a little bit about the work we've done, and then broader resource mobilization opportunities and thoughts. So next slide, please. So for those who don't know, the G20 Joint Finance and Health Task Force, it was established by G20 leaders in 2021. It is hosted, the Secretariat's hosted in the WHO, and reports the co-chairs who are from the Ministry of Finance, Italy and Indonesia. And we work under the finance track. So this is really important because it was a recognition of the critical impact that health and pandemic risk and pandemics have on the global economy. And we bring together a wide range of stakeholders. And there is an annual G20 Joint Finance and Health Ministers meeting. The focus is very much on pandemic PPR, but actually a lot of the convening that we do and the things that have come out are equally relevant for other health agendas. And so I'm really grateful for being able to bring this learning to a broader audience. Next slide, please. So I also wanted to highlight there's really strong regional organization representation, and we've worked really closely with Africa CDC, as well as Africa Development Bank and the AU. And we also have other regional organizations. Last year with Brazil, we worked very closely with Inter-American Development Bank and PAHO, amongst others. Next slide, please. So we have a multi-year agenda, and I think this is really important because it enables some consistency and continuity with our agenda, because we work under the political leadership of the G20 presidency of the year. So from Italy to Indonesia, to India, to Brazil, and now to South Africa. So we provide some continuity on key issues. And we're not a health financing task force, but the issues that relate to supporting prioritization of health spending is really highly linked into how that is financed. And domestic resource mobilization and value for money are really key aspects. And then just at the bottom, it highlights a few of the sort of key areas that the task force has achieved, both in the Pandemic Fund, in the sort of really being the catalyst for the Pandemic Fund, but also providing tools and analytical diagnostics to really better place health and pandemic risk in a wider sort of analysis that ministries of finance commonly use. I'll go into a bit more depth on some of those in a later slide. So next slide, please. So I just wanted to highlight what domestic resource mobilization is commonly understood to be. and why it's really important to think about health spending and priorities within that broader context. So in the narrow sense, it really is, what does the government collect from the population? And then also you can take into account the savings that you can make through efficiencies in public spending, and also the domestic public debt market. And the really key thing is that if you have a very low tax to GDP ratio, you are just not likely to meet the spending needs that you need to grow. And this is absolutely critical. And if you look at the next slide, the additional spending for the SDGs is a really significant amount that is required. And to put this in context, health, education, the infrastructure, these are all really significant needs that are the current levels of revenue just insufficient to achieve. The next slide, please. However, there is significant potential to increase tax raising. And this is actually a really significant priority for South Africa's G20 presidency. And they held a side event on improving tax administration capabilities and really trying to close that gap. But even if we close that gap, on the right-hand side, you still have for several countries, for many countries, there still is this really significant gap. So I just wanted to highlight how this is an issue, not just across health, but right across for many, many countries in Africa. Next slide, please. So then what have we been doing on this topic and this issue, and how do we fit into this bigger picture? So under the India presidency, we built the dialogue between finance and health. And in particular, we looked at particular examples of best practice and sharing of how countries improved their finance and health coordination under the pandemic, and what was an efficient way to do that, and what they could learn from each other. Obviously, each country is unique in the way that it would approach this. And one of the really interesting things was that for many countries, there are things called fiscal escape clauses, which mean if you have an emergency, you can kind of say we can break the bank, and we can have an emergency budget. And for many countries, they have this in place for climate, natural disasters, but they don't for pandemics. So a really simple thing is to share how they different countries have actually increased the scope of this to include health issues and emergencies. Another example is in terms of the federal versus a sort of more regional perspective for many countries, and Spain and Argentina in particular, in their examples highlighted the interaction between centralization and a more decentralized model. And then under the Brazilian presidency in 2024, we were asked to look at innovative financing mechanisms, and in particular, debt for health swaps, and the wider issue about the really significant levels of debt that are really squeezing the amount that countries have left to spend on other areas. And I think the unique thing that we could bring was bringing together the recipients, so those countries that did use debt for health swaps to spend on health priorities, but also those countries that were involved from the debt management perspective. So we had the Debt Management Office of Spain to talk about their perspective. And we also had the MDBs involved, because one of the key learnings was that debt swaps in other areas outside of health actually have been at a much greater scale. So there was a debt for nature swap that was for over $1 billion that the Inter-American Development Bank helped facilitate. And so there is a lot to learn from other sectors, from the role that MDBs can play in these sort of instruments. So this is another way that we have been able to bring in this wide range of stakeholders. We also held a private sector stakeholder event with the Brazilian presidency in the margins of UNGA that year as well. So there's a couple of really concrete examples of what we have been able to do. The next slide, please. So just touching on the priorities for 2025 under the South Africa presidency, I think the really key thing here is placing health financing in the current really changing situation. And the South Africa presidency was very, very keen to focus on pandemic financing within that. So in the next slide, you can see some of the key messages that have come out of that paper that was a joint WHO, OECD, World Bank paper, and that it really is emphasizing this need to safeguard the progress, but also mobilize domestically, and the expertise from the WHO in terms of both helping develop tax-based financing, but also public financial management in health is a really critical part of that. From my own experience sitting in the UK Treasury, health typically finds it quite difficult to be an efficient spender, and that there are usually issues with the sort of speed, implementation, etc. And these are all really important because the better that countries can sort of learn from each other, that this would just release more resources without even increasing your tax take for countries. And then the other work that we've been doing is really this wider perspective on pandemic risk and linking up health, social, and economic vulnerabilities. And this again is not just for pandemics, but it really is important to place the impacts that lower levels of spending on health have, and in the wider growth agenda that all countries have, and into the need to understand the limitations that levels of debt and informality in the economy has compared to the sort of health needs of the population. Just last point on this as well was that Brazil were really keen to ensure that we looked at the social determinants of health as well. So there's this cross-policy perspective where actually policy initiatives in other areas like education, etc., can have a really significant impact on health outcomes. And we need to take that whole of government approach. I'll just skip this slide because I know we're going to run out of time, but one of the things that we've been doing is working to simulate what happens to the financing that's needed. How much can you fill domestically, and how much do you need to look externally? And how is it possible to better coordinate that at country level, and also for the providers of the external finance? And I think one of the key things is that the domestic resource it's far quicker. You have much more control over it, and so it should always be the first port of call. Next slide, please. And just finally, on the South Africa presidency, the Minister of Finance invited the reconvening of the high-level independent panel on financing the global commons pandemic PPR. And one of the really key recommendations from them, and these are emerging recommendations, is the need to unlock domestic resource mobilization. and to double down on the previous goal of 15 billion, and the use of potentially indicative targets to really help push progress in this regard. Next slide, please. So just to sort of sum up in terms of the catalytic effect and measuring impact. So firstly, the G20 agreed that we had a unique role to play in coordinating finance and health. And the support that we bring to this policy dialogue, both within countries and at the multilateral level, placing health as a global economic issue. And, you know, yesterday there was a finance and health ministerial meeting hosted by the AU. And, you know, we were sort of strongly supportive of that. So firstly, you know, we have this role at the political level. And then secondly, in terms of policy, developing these tools in addition to the really important ones that exist. So it's not to, you know, sort of replace anything that the technical experts are providing, but very much to really make some of these linkages that have been, you know, challenging to make previously. And you know, feed that into other areas. And for example, the pandemic funds risk need metric. And then just sharing best practice is also really important in this area. This is just the last slide to just sum up in terms of looking ahead. Clearly, there is just a need for improved coordination between health and finance ministries to really just better understand the perspective, how to align domestically on priorities for health financing and for pandemic PPR. And then I think also placing these opportunities for health-specific revenue raising as part of this much wider domestic resource mobilization strategy, and that wider context. And a key part of that is this idea as to whether health revenue raising should be used just for health, or whether it should be part of this wider pot of money, and the right areas that where you need to bring in, you know, we can look beyond domestic taxation policies to the role of bringing in the private sector. And I think there is huge potential here. Blended finance initiatives are very, very rare in health. And you know, to be honest, I think it's quite hard to understand why we need to look at the barriers more. But this broad stakeholder engagement between the DFIs, private finance, MDBs, public sector and external stakeholders is absolutely essential to make progress on this. And then, you know, we are here to support convening and sharing of best practice. And I'll end there, but thank you very much for this opportunity, and I look forward to the discussion.
Thank you very much, Dr. Serena. Thank you very much for giving us an overall framework of the GFHTF, the mandate, the 2024 framework, and how it links to national implementations and domestic resource mobilization, how to bring in the private sector, and even looking ahead. So now I welcome my co-moderator, who is Professor Busani, who will introduce the next speaker. We are kindly encouraged to keep to time. Let's try to summarize. And for our participants, if you have questions, kindly write them down in the chat. You know, there'll be a Q&A session after all the presentations. Over to you, Professor Busani.
Thank you very much. And good afternoon to all of you, those who are online and those who are present here. Thanks for starting this webinar, Dr. Farmer, and welcome to everybody at NSG, JPS, as well as our colleague led by Dr. Manzi, who is present here at UJ today. We're going to move very swiftly now and take our second presentation. I think it's about 8 to 10 minutes per presentation, so we'll allow more time later on for participants to engage. The next one is Ms. Priya Basu. I think she is online and she will be controlling the presentation from there. She will be talking about the pandemic and catalyzing investment and building fiscal resilience, and you will see that it will all come together after this intervention. Priya, over to you.
Thank you so much, Dr. Busani, and thank you all for inviting me. I'm not going to use slides, so I will speak slowly because I know there's interpretation. Following on Serena's excellent presentation, I represent the Pandemic Fund. I'm the executive head of the Pandemic Fund, which was launched in November 2022 on the heels of the COVID-19 pandemic as the first ever multilateral financing mechanism dedicated exclusively to investing in pandemic prevention, preparedness, and response capacity building in low and middle income countries. And as Serena mentioned, we were born out of the G20 Joint Finance Health Task Force through intensive discussions between December 2021 and September 2022. And we continue to maintain close linkages with the G20 Joint Finance and Health Task Force that participates on our board. We are a financial intermediary fund that's hosted by the World Bank. We have our own governance with a governing board that's co-chaired by Dr. Sabah Nsanzimana, who is the Health Minister of Rwanda, and Dr. Kathy Basri, the former Finance Minister of Indonesia. The backdrop to the creation of the Pandemic Fund was a recognition based on the COVID-19 pandemic that the world was really unprepared to tackle a pandemic, and that despite several health outbreaks in our living memory, from avian influenza to SARS to MERS to Ebola to Zika, every time there was an outbreak, there was panic, but then there was neglect. And pandemic prevention, preparedness, and response was an area that had historically suffered from chronic underinvestments. So, with the leadership of the G20 and broader support from many countries around the world, the Pandemic Fund was established with the goal of breaking that cycle of panic and neglect once and for all. We were able to quickly mobilize $2 billion initially, and then another billion, so $3 billion from 28 donors, including South Africa, which is one of our founding contributors to the Pandemic Fund. We have an inclusive governance model that balances the voices of countries that are contributing resources to the Pandemic Fund and those that are receiving resources. We have 21 voting seats on our board, constituency based, 9 voting seats for all the 28 contributors that include 25 governments and 3 philanthropies, 9 voting seats for all the 147 low and middle income countries that are eligible to receive funding from the Pandemic Fund, represented in 9 constituencies, 2 seats for civil society, and 1 for philanthropies. Now, we've moved forward really quickly. We are not even 3 years old yet, but we've already awarded 2 rounds of funding that have led to a portfolio of projects worth $7 billion, thanks to our catalytic financing impact, and I'll speak about that in a bit. Our portfolio covers 75 countries across 6 geographic regions. These are projects that are focusing on strengthening early warning systems, surveillance capabilities, laboratory strengthening, diagnostics, and health workforce. And 50% of our portfolio is focused on AU countries, the African Union countries. So, which is also where these are countries from where we are receiving the strongest demand. And right now, we're in the midst of allocating our 3rd round of funding. This will be awarded towards the end of this calendar year, and then we'll be launching a 4th round that's going to be targeted to countries with the highest risk, highest need, and lowest capacity. A few unique features or distinguishing features of the Pandemic Fund that I want to highlight for your attention, and they're particularly relevant in the current conversations that are happening around the future of global health financing. Firstly, we are country-led and country-driven. The resources that we allocate are meant to be received by countries on budget, and countries need to decide where that money needs to go in order to fill critical capacities in their capacity gaps, financing gaps in their national action plans for health security or other national plans. So country-led, country-driven, and the way we are operating so far is that we are announcing calls for proposals. We're asking countries or regional entities to work with accredited international implementing entities to submit proposals, but the proposals get submitted by the beneficiaries, which are either single countries or multi-countries or regional entities from amongst the 147 eligible low and middle income countries. So one is country-led. Number two, we are collaborative. We encourage proposals that are bringing collaboration across sectors, actors, countries, recognizing that viruses don't respect visas, pandemics don't respect borders. So, cross-country collaboration is being strongly encouraged, but also recognizing that effective response to health outbreaks requires all of government approaches. That's collaboration across ministries of health, finance, often environment, agriculture, animal husbandry, livestock. 85% of our projects are taking a One Health approach, recognizing the nexus between animal health, human health, and the environment. Thirdly, we are encouraging coordination amongst international and domestic partners. We are non-duplicative, so we don't give money directly. We say, all those partners that are involved in helping low and middle income countries in strengthening pandemic PPR, these come together, and then we'll channel the money to countries through these partners to avoid transactions costs for the country, because otherwise countries have to deal with so many different partners, and each partner has different requirements and so on. So we promote coordination and we're non-duplicative. And last but not least, we're catalytic. We are set up as a catalytic fund with a strong focus on mobilizing domestic resources. So let me explain a bit what I mean by this. So every dollar of funds that we award, we ask international partners to bring their international financing to the project, co-financing, and then we ask the beneficiary or the recipient country or entity to bring its own resources, to invest its own money, because we really believe that our investments are not going to be sustainable unless they are accompanied by resources provided by the country in which we are investing. So this is an ask, and I'm happy to share that actually we've had really good results. The countries that are benefiting from the pandemic fund are bringing their own resources, their own domestic resources to the table. So far, with the $885 million that we've allocated in grants, we've mobilized almost $7 billion. And of those, about 3 billion, 2.5 to 3 billion is actually coming from the countries themselves, from their own domestic resources. And the rest is from international financial sources. So you could say that, right now there are all these conversations going on about, putting countries at the center and incentivizing countries to bring their own resources. In a way, the founders of the pandemic fund were ahead of the curve. The Lusaka and Accra agendas were somehow built into the DNA of the pandemic fund, and we seek to further maximize our catalytic potential in the coming years. And just to give some examples, so we have, as I said, we have projects across 75 countries. Tunisia is bringing 30 times as much in its domestic resources as it's getting from the pandemic fund. So a $25 million pandemic fund is leveraging 30 times as much from Tunisia from its own domestic resources. Indonesia is bringing 9 times as much. Rwanda is bringing 6 times as much as the grant that we've awarded through its own domestic resources into the project. South Africa is is matching the amount that we've provided. And these are just some examples, but just to say that, the hypothesis here was that some grant money will incentivize countries to bring their own resources, and that is being borne out. We have proof of concept. The type of investments that we're making, as I already mentioned, these are in areas like early warning systems, surveillance, laboratory strengthening, diagnostics, and the health workforce. And in each of these areas, when we talk about these investments that the countries are making, they are taking all of government approaches. So when it's surveillance, then it's surveillance of both livestock, wildlife, as well as human diseases. Laboratories, we're seeing veterinary labs strengthened and human labs strengthened, and then sort of being connected. Diagnostics is also across animal and human health sectors. We talk about health workforce, it's training of doctors, nurses, lab technicians, field epidemiologists, but also veterinarians and animal health workers, and very importantly, community health workers. Communities really are at the center of what we're doing because we all recognize that pandemics begin and end in communities. So our projects are involving communities both in the design as well as in the implementation of projects. Given your focus on women, children, and adolescents who happen to be the most vulnerable during public health emergencies, I just want to share that many of our projects are really bringing in women's groups, youth groups, and so on into the design and also into the implementation of projects. We are disease agnostic, so we don't know what the next outbreak that could turn into a pandemic is, and so the investments we make help countries detect and contain infectious disease outbreaks, across a variety of different pathogens, regardless of what the pathogen is. The goal is to build that capacity to be able to quickly detect and contain, ideally to be able to detect in 7 days, report in 1 day, and contain in 7 days. And perhaps the last message I want to share with you is that very often, unfortunately, these discussions around pandemic prevention, preparedness, and response take place in a silo. We believe that these investments that we are making in pandemic prevention, preparedness, and response capacities are really critical to strengthening health systems and achieving universal health coverage. And that what we learned, if there's one lesson we learned from COVID, was that investments that countries had made in health system strengthening had neglected some of these core capacities that allow us to quickly detect, contain, and prevent an outbreak from becoming a pandemic. We allowed a tiny little virus to disrupt the entire world. And all of the analysis that we did during COVID and since then, various independent panels, the World Bank, WHO, all showed that the expenses that are needed to invest in building that capacity to get all countries to the right level of preparedness to be able to quickly detect and contain outbreaks and prevent them from becoming pandemics are a tiny fraction of the cost of not being prepared. So really, our efforts are to get, our ambition is to get all countries, all low and middle income countries, to that right level of preparedness, so that we can protect communities from and people around the world from another pandemic. So thank you for your time and attention, and back to you, Chair.
Thank you very much for that intervention. I took note of a few fundamental things that you said, especially the last one, regarding the cost of not being prepared. And we have learned as humanity over the last number of years that not being prepared costs much more than investing in prevention and in being prepared. And secondly, I took note of the emphasis you made around the community approach, being community at the center. We have learned from the management of other pandemics that if you do not put community at the center of what you prepare, at the center of how you respond, you might not have the desired impact or desired results. And thirdly, you spoke about the all of government approach, which is significant. And we've learned both in the healthcare space, but in several other social policy responses. That unless you take a whole of government approach, you might be leaving other sectors of government behind, and consequently might not be maximizing the impact. Now, you gave us a global overview where you mentioned several countries. We're now going to move into the next segment, which my co-moderator is going to be dealing with. And she will now be focusing and giving on country perspective so that at least we have a sense of what is happening in certain countries, such as Sierra Leone, which was mentioned, Indonesia, and so on. So I'm going to give it back to you, Dr. Linda, to take care of the country perspectives before we move into the next moderated discussion. Please, those online, continue to write your questions. We are noting them, and those who are making input will be responding to them. Thank you. Dr. Linda?
Yes, thank you very much, Professor Busani. So as we've heard from Professor Busani and from our two speakers, we've heard from the Joint Financial Health Task Force and my colleague, and now from the Pandemic Preparedness Fund. So we want to have country experiences, who've had experiences from both. And I'm happy to introduce the first speaker, who happens to be my financial secretary, Mr. Matthew Denji, who is the Finance Secretary for the Ministry of Finance of the Republic of the Great Sierra Leone, and also from Dr. Oscar Tihabuthi, who is the Director General for Healthcare Services and Accreditation, Ministry of Health, Republic of Burundi. So you each have 10 minutes each, and please let's kindly keep to time, and you are to focus on your experiences from the JFHTF and also the Pandemic Fund, and how have your respective countries leverage these finances to really strengthen health systems, the lessons learned from implementation, and how have they tied up to regional initiatives, and how have women, children, and adolescents been featured in these plans. Thank you, and over. Mr. Matthew Dingy, welcome.
Thank you very much, Dr. Linda Farmer. Thank you to the Global Leaders Network for extending invitation to Sierra Leone, and to me specifically to speak on behalf of the Ministry of Finance. And of course, I'll also speak on behalf of the Ministry of Health, because this issue cuts across financing for health and what we are doing as a country to support the response for the Pandemic Fund project. I want to also thank the President of South Africa on behalf of the Republic of Sierra Leone, and our President, for the inspiring leadership he has demonstrated in championing issues of women health, children and adolescents through the Global Leaders Network. I think firstly, from your question, I want to start from that very end in terms of what Sierra Leone has been doing in terms of supporting women, children, and adolescents' health issues in terms of the strategic plan which the Ministry of Health is actually implementing. On that end, I think firstly, there is the policy and legal environment which is being in place, it has been instituted, wherein we've seen revision and enforcement of laws. Example, we are now talking about the prohibition of the Child Marriage Act, which is ensuring that we don't have children or girls who are underage being forced into early marriage. So that act is actually supporting that. And of course, we are also in the point of, we are at the state of pioneering the advocacy for the Safe Motherhood Act and legal support to protect women and girls from violence and exploitation. And on public health, we are looking at expansion of adolescent-friendly health services, integration of sexual and reproductive health into primary health, improve access to family planning, mental health supports, and survival centers services for gender-based violence. And in enabling the learning environment as well, we are scaling up support to school-based services, comprehensive sexual education, menstrual health support. I think in Sierra Leone, one of the flagship programs we're implementing through the office of our First Lady is the distribution of sanitary pads to school-going girls, so that at least during their menstrual period, they can still be able to access education. They go to school and during those periods and still feel comfortable amongst their colleagues. We are reducing, this is helping to reduce the school dropout rate, especially for girls, and empowering girls through knowledge and life skills. And then, of course, on community engagement and ownership, community dialogues are being held on harmful gender norms and the importance of education, engaging local leaders and championing girls' rights education. And on social assistance and livelihoods, economic empowerment for young women and families, social protection interventions, and poverty-targeted programs to reduce the incentives for early marriage and early pregnancies are also being discussed, and systems being put in place to ensure that these are achieved. And lastly, on leadership and coordination and the results, we are strengthening multi-ministerial coordination, ongoing monitoring, evaluation, operational research, youth inclusion in strategies, and accountability mechanisms to track progress and resource use. As a result of this, we've seen some significant impacts over the past couple of years, a reduction in our infant mortality rates from about 354 per 1,000 baht to 70 per 100,000 baht, which is our target by 2030. We have seen a 50% reduction in infant mortality from 56 to 37 per 1,000 live baht, and we've seen a 50% increase in health worker density from 13.4 to 20 per 10,000 population, and there's a target to decrease by 10% out-of-pocket expenses for health-related issues, for especially women and adolescents. And all of this is helping us to support investments in women, children, and adolescent health programs in Sierra Leone. Secondly, on the pandemic fund itself, as you have mentioned, Sierra Leone has benefited from the pandemic fund. And of course, we are an example of countries that have been severely hit by some of these outbreaks, starting with Ebola from 2014, and then, of course, which was very specific in our sub-region, Sierra Leone, Guinea, and Liberia. I mean, that was a difficult situation for Sierra Leone. And of course, in 2020, the COVID crisis also struck, and that's also affected Sierra Leone. But through the investment in the pandemic fund, which Sierra Leone has also benefited from, we set up a national public health agency in Sierra Leone through an act of parliament, and they have been in the forefront in terms of developing our health systems to respond to outbreaks that do happen globally or even regionally. Sierra Leone has benefited from the total disbursement, which the previous presenter just mentioned. We have benefited from about $20.1 million, covering 2025 to 2027 through the pandemic fund. And what have been some of the impacts in terms of results recorded just in this first year of implementing the pandemic fund in Sierra Leone through our public health agency? We have seen strengthened community-based surveillance and timely detection, notification, and response rates. That has actually improved. We just saw recently the Mpox outbreak that was in Sierra Leone. As a result of this pandemic fund, the National Public Health Agency was able to really ramp up the surveillance and detection mechanisms in country right across all the 16 districts to ensure that within the shortest possible time, we're able to reduce the infection rates quite significantly. And now we can see that's actually within control. We have also seen strengthened rapid response at district level through the procurement. The project has procured vehicles for the National Public Health Agency, about 8 vehicles. So that has improved their mobility and response rates to really visit areas that are prone to outbreak of diseases, and how they can actually deploy resources quickly to address these outbreaks. We have seen investments in early warning systems to detect and escalate signals, and also to support any other health events that could occur in some of these localities, or unusual health events that will occur in some of these localities. So that has actually come through the support of the pandemic fund. And they have strengthened the infodemic management capacity within the National Public Health Agency itself. And then lastly, we've seen a long-term improvement in surveillance and laboratory systems that have been developed. So all of this within a period of 1 year has been some of the benefits that Sierra Leone has recorded through implementation of the pandemic fund. It has been done not only through our public health agency, but implementation has been also in partnership with like the World Health Organization here in Freetown, the FAO, and UNICEF. All of them have been working collaboratively with the Ministry of Health and the National Public Health Agency to support the implementation of these programs. So these have been some of the impacts or benefits. So from a Ministry of Finance point of view, of course, whenever we talk of external resource coming in to support whatever sector, be it health, or education, as the case might be. For us, it's a welcoming news, it's a welcoming idea, because that is actually creating a fiscal space in the budget to address other priority areas for government. So as a result of this intervention of the pandemic fund, we've seen how that has created fiscal space for government to actually address other challenges that we face in other sectors. So all of these burdens have not been coming to the budget directly, but have been absorbed through the pandemic fund. So it's timely we are discussing domestic resource mobilization. How do we ensure? Of course, the pandemic fund is there, and the strategy is that to see how countries can also contribute to the fund through the 1-to-7 ratio, so that whatever resource or dollar you receive, how can you mobilize an extra $6 or $7 to ensure that this program is sustainable going forward as a country? Coincidentally for us, Sierra Leone, domestic resource mobilization is our theme for the 2026 budget, which we are now planning and discussing. And stakeholders have actually started the discussions in terms of what can we do as a country to improve on our domestic resource mobilization, because we need to ensure that in the current avenue where we see overseas development aid declining, we have to make sure we ramp up our domestic resources to fill in the gap and ensure that there is sustainability in terms of implementing programs in our various sectors, and especially focusing on health. For us now, domestic revenue to GDP for Sierra Leone is about 9.3%, following the rebasing of our GDP 2 years ago. So we see that the effort is a little bit low. As the first presenter mentioned, the target or the norm globally now is at least revenue to GDP should be at least 15%, but we are 9.3%, and we are targeting to push that to about 10.4% of GDP by 2026. That is the next year budgets that we are preparing. But how do we intend to do that? Firstly, like I mentioned in our theme, we are looking at domestic resource mobilization. We are looking at both traditional sources and innovative sources as well of financing that will bring on the table to ramp up our resource mobilization. On the traditional sources, we have developed what we call the medium-term revenue strategy, which covers the planning period 2025 to 2028. And in this strategy, it focuses on how we widen the tax base on areas that we think there is still potential for us to expand in terms of, especially in the informal sector, how do we bring them on board and widen the tax base? And we are focusing on investments in technology. I think our ultimate objective is to make sure through the National Revenue Authority that all our tax handles are fully automated and digitized, such that human interaction in our revenue administration systems are really, really minimized, so that we can really account for all revenues that are assessed and collected and deposited into our consolidated revenue fund. So investment in technology is very, very key in terms of our strategy to enhance domestic resource mobilization. And then, of course, compliance is also another area we are looking at very critically. We want to make sure that we improve compliance through how we through tax education and through enforcement of the tax laws, and bringing defaulters to book and naming and shaming those that are really not paying taxes, and we ensure that the tax field is actually level for every taxpayer. So these are some of the strategies we are doing on the traditional aspects. But what other tax handles are we specifically looking at if we want to target this health sector funding in support of pandemic or outbreaks that could happen? Specifically in our engagement during the policy hearings, I'm happy we got some feedback from the Ministry of Health on how can we really target some of these sin taxes, that the excise tax on like alcoholic drinks, tobacco or cigars, and sugary drinks. How can we target some of these revenues from those tax handles and ring fence them, so that, because the use of these commodities or products in country by citizens is actually affecting the health sector, because they get people ill and then people have to call on the health system to respond. So we want to see how we can set up a mechanism of how we can ring fence all these sin taxes on tobacco, cigars, sugary drinks, and then see how those can be utilized to support intervention in the health sector. We are looking at the possibility of also increasing the GST by perhaps 0.5 to 1%. to take care of healthcare intervention. So we can ring-fence that. We say that goes specifically for health. And then lastly, on the traditional aspect, we are looking at the fuel levy. Fuel levy is also another area in our formula for the petroleum that we can also bring in a fee or a charge for every liter of petroleum that is bought in the pump, and see how that can also be ring-fenced and put into a special fund, which we can always fall back on whenever there is an outbreak, so that we can quickly respond to some of the issues that instead of wait for international partners to come in, we'll have saved some funds aside to respond. One thing I just want to mention again, I think we also have an innovative area. We're seeing a lot of investments in infrastructure in Sierra Leone. And now through innovative financing like public-private partnerships, most of the projects on roads, infrastructure, water, we are encouraging contractors or companies that want to invest in that to charge toll fees. So we want to see where some of these toll fees, we can also ring-fence like a portion of that and put into this special fund also to address emergencies on health sector issues or pandemic response. So toll fees can also be another source for us to really raise revenue to match whatever partners are bringing in. On the innovative financing, which is the new area, our focus is on climate revenue. We think Sierra Leone is really ripe in terms of our resource base for us to harness climate revenue through carbon trading. We've had some interventions. We see a lot of demand coming in from companies that want to really invest in Sierra Leone to trade in carbon, and some concessions have already been issued out. We will be actually meeting with most of these companies to see how the proceeds from this carbon trade, we can have some arrangement for revenue sharing that can be coming into the Consolidated Revenue Fund, and how we can use some of those to also address emergencies in our health sector. Debt swaps is one of the options also discussed by the last presenter, especially for health. We have one project at hand we are looking at currently, which is the debt health swaps. We have one creditor we are negotiating with now, which is the Saudi Fund. We are putting the proposal together to see how they can actually forgive our debt obligations on the Saudi Fund and swap that and use those monies to invest in the health sector. Last but not the least is we will also be providing counterpart funding through the budget for this pandemic fund over the medium term, and bring it in budget so that we'll have visibility in it to make sure that as and when we receive resources from the global network for health, through the pandemic fund, we'll also match government's contribution. We've done it for other health sector players like the Global Fund and other donors that are supporting the health sector, Gavi and the rest. We usually do matching funds for immunization and all of that. So it's something we intend to also replicate for the pandemic fund. So I think I just want to stop here for now. You mentioned 10 minutes. I think I'm way above the 10 minutes. But I just hope that my interventions on behalf of the Ministry of Finance for Sierra Leone on how we intend to really make sure our domestic revenue efforts match the demands for the emergencies of our health sector are actually something which we all can learn from and support so that we can be successful in that. Thank you very much.
Thank you very much, FS. I think I have to be friends with your office henceforth.
Thank you. You're welcome.
You. All right, we want to hear from the next speaker, our director from Burundi. Take over, please. Thank you.
Merci beaucoup, Linda Fama, pour votre modération. Merci. Bonjour à tous qui m'écoutaient. Et je voudrais d'abord remercier le Global Leaders Network pour cette opportunité de partager l'expérience du Burundi sur une question qui nous concerne tous, de voir comment les investissements que nous mobilisons, que ce soit de l'extérieur ou de l'intérieur, puissent se traduire par des gains concrets, équitables pour les femmes et les enfants et adolescents dans notre pays. Et permettez-moi de vous annoncer que le Burundi met en œuvre une politique de gratuité des soins chez les femmes enceintes qui accouchent et les enfants de moins de 5 ans depuis plus de 20 ans. Et il y a eu la gratuité de la scolarité pour les jeunes élèves pour le fondamental depuis plus de 20 ans. Il y a des initiatives, surtout saluons l'initiative de son Excellence, la première dame du pays, qui touche sur les questions du bien-être de la femme et de la jeune fille. Et nous mettons en œuvre un plan de développement de la petite enfance au Burundi parce que nous avons compris que si nous ne faisons pas attention, si nous ne mettons pas d'efforts pour les jeunes enfants, nous ne pouvons pas bâtir un pays développé parce que tout commence par le jeune âge. Et tout cela nous a amené à de bons indicateurs de santé. Par exemple, en 2010, nous enregistrions à peu près 500 décès maternels pour 100 000 naissances vivantes. Pendant que maintenant, en 2025, nous avons diminué de plus de la moitié de ce taux. Avant la mise en œuvre de cette politique de gratuité, nous enregistrions plus de 100, à peu près 120 décès néonatals pour 1000 naissances vivantes. Et actuellement, nous sommes à moins de 30 décès. C'est grâce à ces politiques qui se focalisent sur le bien-être de la mère et de l'enfant. Pour renforcer pour les acquis de ces politiques, je dois signaler que nous sommes à l'étape de finalisation d'une stratégie de financement de la santé qui d'ailleurs vient d'être validée techniquement et attend son adoption politique, et tout en pensant que d'ici quelques mois, cette stratégie de financement de la santé va être rendue opérationnelle. Dans cette stratégie, nous avons identifié tous les mécanismes innovants de financement de la santé pour pouvoir essayer de diminuer la dépendance extérieure au niveau du financement de la santé parce que actuellement, nous sommes à plus de 50% dépendants du financement extérieur. Et cette stratégie sera un outil clé qui va orienter nos efforts nationaux vers le développement des soins de santé primaires accessibles à tous, surtout qui va toucher sur les catégories les plus vulnérables, surtout les jeunes enfants et les femmes. Et dans notre pays, le choix stratégique, c'est de développer les soins de santé primaires, surtout renforcer le niveau district et qui va nous permettre de prendre en charge plus de 80% des problèmes de santé publique. Et nous l'avons pris comme socle de la couverture sanitaire universelle au Burundi. Et il y a déjà, avant même l'opérationnalisation de cette stratégie, il y a déjà des efforts de l'engagement politique au plus haut niveau. Par exemple, actuellement, nous sommes en train d'évoluer vers l'assurance maladie obligatoire parce que nous avons vu que les mécanismes de financement actuels ne parviennent pas à toucher les catégories les plus vulnérables. Je donne l'exemple maintenant pour tous les hauts cadres de l'État qui sont
Yes, we can hear you now. Austin, yes. Dr. Ntiaboze, can you hear us? If you can hear us, perhaps turn off your camera and see if that helps. Dr. Linda, we'll be guided by you. Should we advance with the agenda and see if we cannot get Dr. Ntiaboze back?
I think
Spring, Dr. Oscar from Burundi, his network has disconnected, but he's trying to join back. And I agree that probably Dr. Linda can guide us on how we move forward.
Thank you, Diana.
Okay. Okay, well then we can move to the next agenda item, which was to be a moderated discussion, and Professor Busani was to facilitate that. So, and then do we make time when he comes back so he can wrap up?
Yes, please.
Yes. Okay, so let's move for the sake of time. Over to you, Professor Busani.
Yes, no, thank you very much. If you recollect, we'll have him do his closing remarks later. So now we've had the country perspective, which is important because it ties in with the earlier intervention that was made. I think it is important that we get to understand how each of these countries are responding. And the two countries that we listen to now is, countries that are post-transition societies, and it is useful that we can also mark the lessons taking place there, not just on the bigger countries as well, such as South Africa, Egypt, and so on. So thanks for those interventions. We now move quickly to the session where we will then get some input from civil society, as it's called broadly, including the partners. So we've got two interventions there, and I'll come in later. Myself, which is Rajas and Agri. Rajas, are you in? There you are. Welcome.
Hi.
Please go ahead.
Thank you very much for having me today, and then it's great to join the conversation. And just a very brief introduction before I start, and it will help situate the remarks that I am planning to make. My name is Rajat Khosla. I head the Partnership for Maternal, Newborn and Child Health. We are the world's largest alliance working on women, children, and adolescent health issues with over 1,500 partners in 130 plus countries around the world. And that bit of introduction was important because recently we did a survey with these partners in 130 plus countries that I just referred to understand what has been the impact of aid cuts on the work that they are doing. And it does paint a very grim picture, and I will come to the specific issues and their manifestations from a women, children, and adolescent health perspective, and what we have heard from our financing colleagues in a moment. But about 84% of the partners that responded reported that they were affected by the aid cuts, and between 60 to 65% of them reported either suffering significant or severe cuts in their programming operations related to women, children, and adolescent health issues. So, colleagues, what we have heard today by esteemed speakers speaking from pandemic perspective, from financing and economics and country perspectives, if we look at it from a perspective of women, children, and adolescents' health, I think it's safe to start by saying the gains that we have worked very hard on for the last few decades are currently severely at risk. We are seeing a rollback in the very investments that make the difference between life and death for millions around the world. And with that, we are discussing as we were discussing during the first webinar in the launch series with the Honorable Minister of Health from South Africa, how major donors announcing deep cuts to their overseas development assistance for 2025-27 is reshaping the financing landscape. And at the same time, we are also looking at highlighted decline in domestic health spending in many low and middle income countries around the world. And this decline forces families, individuals to cover health costs out of pocket, which deepens poverty and exacerbates financial hardship, including many already women and children. So, colleagues, the path to true sustainable development requires nations to fundamentally shift from reliance on official development assistance, which has been very, helpfully articulated by previous speakers as well, to self-financing model through robust domestic resource mobilization. And this transition is above all about governance and about changing mindsets. ODA should no longer be seen as a substitute for national budgets in funding essential services. Rather, it must strategically fund global public goods such as Priya was talking about, pandemic preparedness, surveillance, climate change, and similar transnational threats. This will allow the governments to free up the fiscal space and focus on mobilizing domestic financing for the health and well-being of the populations and to the issues that both the previous speakers from countries spoke about. At the center of this effort is ensuring that national health budgets prioritize essential services for women, children, and adolescents' health and well-being with a strong focus on sexual and reproductive health and rights, issues which we are finding systematically being left behind in the prioritization efforts that are presently happening. The Lancet Commission on Investing in Health, most recent report, found that cutting the risk of dying before age of 70 in half by 2050 is achievable by prioritizing 15 conditions, 8 of which are actually related to maternal, newborn, and child health. I think the surprising question we all must be wondering is that why is that not then the top priority investment in the countries that we are talking about? The Commission also argues that these essential services should be funded by domestic resources and prioritizes through the national budgets. Colleague, this is a very compelling case for a strong priority setting approach, ensuring that essential services for women, children, and adolescents remain at the forefront of progressive realization of universal health coverage. In parallel, we must change the narrative towards high returns on investment, contributing to human capital and economic growth. And we at the partnership have been working very closely with the governments such as South Africa in documenting, for instance, returns of investment and costs of inaction, looking at adolescent health and well-being in particular. We must compel finance ministries to see women, children, and adolescents' health issues not just as an expense, but as a direct driver of economic productivity, stability, and prosperity. With domestic financing as the cornerstone of sustainable health systems, PMNCH recently launched its new strategy for 26 to 2030, together with a critical role that our partners, Global Leaders Network for Women, Children, and Adolescent Health plays, underscoring the importance of mobilizing national resources to improve the lives of women, children, and adolescents. Strengthening domestic financing, therefore, is not only about sustainability, but also about health and sovereignty, enabling countries to set their own priorities and to lead their population. And just a couple of final concluding remarks before I hand it back to you, Chair, because one of the things that we want to emphasize that means working together on budget advocacy and ensuring that health of women, children, and adolescents is prioritized in national health plans should be a collective responsibility. Just as importantly, we must move from budget allocation to actual budget executions, turning commitments into real health spending that reaches vulnerable community. We need a lot more of this happening through participatory budget processes, but also by instituting social accountability approaches. For this, strong partnerships around financial accountability become essential. Multi-stakeholder platforms such as ourselves are increasingly identifying ways to work with the architecture at the financial end, including those such as the ones that we work at in different countries in Africa, the Collaborative Advocacy Action Plan Initiative, the Global Leaders Network, to identify ways in which meaningful investments can reach those who really require the most. Such collaborative structures gather government, development partners, civil society, private sector, and other stakeholders at one table to ensure financing and health strategies are not imposed but are instead founded on country ownership and national priority. And just finally to say the practical value of MSPs lie in their ability to enforce coordination and coherence. They ensure financing is strategically channeled to build long-term capacity rather than filling short-term gaps. This means investing in strengthening key domestic institutions such as tax administration and public financial management system. Thank you again for the opportunity to share some reflections. And if there is more time, I can come back to other aspects of our conversation as well. Back to you.
Thank you very much for the conversation, for that intervention. Please do check on the Q&A platform. There might be questions for you and questions for everybody else who made a contribution. Let's move swiftly now to Agri Aluso, who's Executive Director of RANA. Agri.
Thank you so much, Professor. My name is Agri Aluso. I'm the Executive Director of Resilience Action Network Africa, which is RANA in short. We are a hub for African advocacy actors working across related issues impacting resilience capacity of Africa, which includes health system resilience. We bring together partners aligned in the vision of creating a resilient and healthy Africa that is safeguarded and led by African solutions. It's my pleasure to speak to you today on this very important subject. I think all of us on the advocates or CSO side have been very concerned about the continuing trend of underinvestment in the health and continued over-reliance on external financing of a very, very critical service sector of health. And I think really mobilizing health financing, if I may use an analogy that I had from a partner, is like making a rice cake, which needs fire from the top and fire from below. And clearly the CSOs are the fire from below that really work to help build the political agenda and drive accountability in this very challenging context. But of course, we are very cognizant of the huge task that is entailed in mobilizing adequate health financing, particularly in the African continent, which continue to lag behind despite being heavily burdened with disease. Many of us know the disproportionate disease burden that Africa holds, comparative to its very relatively small population. And of course, also Africa is facing a very difficult, situation of, balancing very important but challenging scenarios of, debt, which I think has been mentioned, meeting development needs and managing resistance to tax hikes. You've seen a lot of, strikes, including my own country, Kenya, where, whenever tax is proposed, of course, justifiably so, there's been resistance. So it's a situation that is very, very challenging for many. And of course, one of the scenarios which we all know that therefore, because of all these challenges, Africa spent very, very little on its health. And what we've seen consistently is not many countries meeting their own commitment that was set in the Abuja more than nearly 30 years ago. And what we've seen is less than 10% of the GDP being spent on health, leaving a huge balance of, just that translates to just about 4.5 billion, which falls short of the 26 billion annually that is needed to meet the evolving health needs in Africa. And of course, we have also seen the debt scenario that many African countries are paying more to debt servicing than they're putting to health. And really, as we now move into exploring ways in which on how we can help change or shift the needle in the right direction, I have been persuaded by the conversations or the processes that have been led by different leadership spaces, including the G20 and WHO, particularly the work they did around economics for health for all, which really asked for a rethink of the underpinning principles of the policies that really inform health investments. And therefore, my proposition and what we've had from partners, we had a very robust conversation at the beginning of this year, not far ago. That was on April in Nairobi, where we were reflecting on this very, very troubling trends of the shifting trends in the ODA and the continued underinvestment in health in Africa, and now the challenges that we are facing, the existential threat that are facing our population. What the partners in our network have been consistently trying to tell us is that we need to have like a real critical change of mindset, because a lot of our countries look at health as an expenditure, an avoidable cost, which they would rather, anytime they're faced with pressure to cut down on anything, health is one sector that is that is easily cut. But I think we need to really position health as a critical, vital investment for our human development and a core factor in our economic resilience. And I think that's something that the G20 can help us position. We also need to push for integrated approach in health. That's something that we, recently in our conversation towards the Africa Climate Summit too, we had, robust conversation, and the recurring suggestion, and I think this resonated with what Dr. Serena said earlier, that health of population is linked to a number of other, sectors: climate, education, agriculture, infrastructure, and more. And this calls for adopting health in all policies approach, an integrated multi-sectoral strategy that ensures health considerations are embedded into every decision-making process. And embedding health in all policies, it's not just beneficial, it's essential. It will help in fostering collaboration across different ministries, the whole of government approach that was talked about. But it also helps in creating, synergies and effectiveness, in the implementation of this, addressing the structural determinants of health. But more importantly, it opens up opportunity for increased domestic financing through cross multi-sectoral resource mobilization, and can also create opportunities for innovative financing mechanisms that support health investments. And we think G20 as a premier forum for international economic cooperation has a huge, unique, powerful role in catalyzing this, the adoption of this kind of mindset that will help us really shift the policies that would help open up more opportunities and more spaces for health financing, both at the regional, global, regional, and domestic level. And of course, G20 in doing so can act as a powerful force that aligns global economic policies with health priorities, and foster an environment of conducive partnership that we all think are important. And really, as the civil society organizations, we also think we have a very critical role in catalyzing political action to embrace health as an investment, and also to serve as credible voices to hold governments accountable, particularly for all these many commitments they have made, which have not been fulfilled. But we also, work continuously, closely with community and grassroots organizations, and through that, we help in creating political pressure for the reform that is needed. And of course, we also facilitate knowledge sharing and capacity building for this multi-sectoral collaboration, which targets health sector investment. Thank you very much.
Well, colleagues, as we know, from a university or academic community point of view, we have learned from previous pandemics. For an example, the HIV and AIDS pandemic, we've learned recently from the COVID pandemic that if we have a very engaged research community doing both the biomedical as well as studying the social determinants of pandemics, we are most likely to have very effective and responsive responses to these pandemics that we are talking about. Many of you will recall that during the AIDS pandemic, there was a large community of researchers within the university and outside of the university who advanced biomedical research and also helped to shape public policy by identifying what were the social drivers or the social determinants of these pandemics. On the basis of that research, the states, the development partners in the region as well as beyond were able to have appropriate responses. For example, we understood something called key population groups. As a consequence of this research was emerging on what was regarded to be key population groups, we are able then to target your health responses instead of having a spray gun approach. We saw it during the COVID pandemic as well. That's the nexus of research from those who were doing biomedical as who were doing social research assisted in formulating very effective responses to the COVID pandemic. And so in summary, the input or the responsibility or the contribution of the research community, one is that of identifying or supporting research directions so that we know exactly what direction should research be taking place, both on the biomedical as well as on the social side. But most importantly, it is also, as it has emerged in some of the previous inputs, that the university must dedicate resources towards the project of building state capacity. I have been to Liberia myself. I have been myself to Sierra Leone. I understand some of the recent efforts of building state capacity. We heard from the secretary the input that he was making, that all of it is pivoted on the ability of the state to respond. The colleague from Rwanda as well, there's been a lot of investment on building the dynamic state capacity. And so it is important that the university must make a contribution, which is why also having partners like the National School of Government here is important, because they have the responsibility of building state capacity. You cannot build a resilient health system, even if you have the financial resources, unless you have a robust state capacity that is able to implement some of these strategies. And of course, the university has an important role to play in as far as R&D is concerned, both from the scientific side and also from the social science side. We know that most of the pandemics now are not the same as the pandemics that people might have been used to over the years. And so we need to sharpen our insights and tools and instruments of responding so that we are also more innovative in how we are responding. For an example, we know in the previous few years, the social media has come to play a very major role in driving pandemics in society. The university must assist in studying and understanding how then you can innovate and respond, so that from a mitigation point of view, you can use instruments such as social media. In this regard, of course, beyond the university, we also have other civil society organizations that have a big role to play here, including the media, because people need to be educated. So, finally, I am saying from a university, from an academic and research community point of view, there is a major role to play, driving research directions, doing R&D, supporting the efforts of building state capacity, but also supporting knowledge management as a factor of some of this work. We have learned from the previous pandemic, and we know it is possible that we can do more in the current situation, including transferring and sharing some of the ideas. And the reason why today, for example, we have those case studies from those two countries is because, given their own histories, given where they are, we then get a better sense of how the problem itself is responding. And of course, we're talking about, as I said, key population groups in this regard being women, children, and the adolescents. And it's important that you do that in a much more targeted way in order to be able to respond. The good thing, I suppose, that is taking place now is that, as is the case with this initiative, is that once we are focusing on strengthening health systems, but we are also regional and global, and we're not just narrowly focused, as might have been the case in some of the previous interventions. And so that's what the university could do in this regard. And so now we can give this to the audience to interact. There are questions that are on the platform. Maybe to make it easier to respond to these questions, I'm going to request, we'll give a minute each to everybody who has spoken on the program, starting with the first, those who were in presentations and the panelists. You can pick a question and respond in the order in which we appear on the program. I think it might be fair to do that. I'll give you a minute each to everybody who is on the program, who was making a presentation, all the way up to the last one.
Can you ask him to come here and speak?
Can we start? You can read the questions, the panelists that are on the Q&A platform. As you can see, there is 4 of them. I'm going to give you a minute each to respond. If you want to pass, you can say pass. Dr. Serena, then you go to Priya and everybody else. But if you want to respond, please do respond. We'll give you a minute each. Thank you.
Thank you. So just to check, shall I come in now? And then,
Yes.
Okay, great. So So I think two questions are most relevant to some of the things that I covered. So the first one from Priscilla on the focus on pandemic preparedness financing and aligning with advancing SDG health targets. So I think just to emphasize that the Joint Finance and Health Task Force sits between kind of finance and health, but there's also the health working group that has done an enormous amount over the years. And so I think just to highlight that this isn't the only health discussion in the G20. I think the investment in core health capabilities is absolutely essential. I think if you look, and the work that we've done is obviously health systems are at the sort of, they're the essential foundation for any response. So I think firstly, and what the paper on pandemic financing that was done this year at the request of the South African presidency is that we need better evidence on what are the best investments that give that really important improvement everyday health outcomes and can help improve future pandemic response. So I think that's the sort of really core thing there. And then for the second question, what's a suitable tax rate? I think it obviously depends on the response to different tax rates in different countries. So it's behaviorally driven by the country. And it also depends what sort of tax you have. So excise taxes do increase general price levels quite directly. Sin taxes are really, really important policy tools, but they also do increase average prices. Whereas, in many economies, the bulk of tax revenue comes from income taxes and from other taxes which don't have that effect. So there's this question about what is the right tax strategy to ensure that you effectively generate income without dampening down economic activity. Thank you.
Thank you very much for that. Let's move on to the next one. Priya.
So very briefly, agree with the point that Serena just made to Priscilla's question. These investments in pandemic prevention, preparedness, and response capacities are really core to health system strengthening. They should not be seen as some separate silo, as I also mentioned in my remarks. These are critical capabilities. And the way to think about these investments and the way the pandemic fund is thinking about these investments and acting on this in the countries that we're working in is that we need to build that capacity so that it can be ramped up in times of crisis, right? So it can help these investments in surveillance and laboratories, in health workforce strengthening and diagnostics, the kind of areas that the Secretary of Finance from Sierra Leone mentioned. And it was very heartening, by the way, to hear about how the pandemic fund is helping Sierra Leone, because this is exactly the kind of thing we're trying to do. But these kinds of investments need to be made in a way that there's capacity to surge. And maybe one other associated point. So last year, in the wake of the Mpox outbreak in Africa, the pandemic fund provided emergency financing to 10 Mpox affected countries. And in one case, Rwanda, after Mpox or during Mpox, it also suffered from Marburg. And they told us that the investments that they had started to make as part of the Mpox detection and containment effort actually helped with Marburg as well. So this is exactly the kind of thing that we want to do. We want to build health systems that are fit for purpose for today and for tomorrow. So thanks again. Nothing more to add.
Thank you very much, Matthew.
Yes. Is it? Can I proceed?
We can hear you, yes.
Yes. I think I just want to respond to the second one on the tax rate. What tax handles or whatever, which right strategy should we use for situations like this? I think the best approach is to use indirect taxes. Because for indirect taxes, you can specifically target certain products or certain goods that we know are perhaps high-end goods, which only a certain set of well-placed individuals in society will want to consume, and not just essential goods which the poor or the rest of the population will actually consume. So we believe we target such goods through indirect taxes and put a levy or a tax on those goods through the sin tax and excise taxes we have mentioned. And then we see how we can ring-fence those funds and use that to support interventions in the health sector. So direct tax will not be the main approach because we know that's general and it affects almost everyone. And most government depend, the previous speaker mentioned, most government depend so much on direct taxes to take care of almost everything, to pay salaries, to run the government institutions and take care of other governance issues. So I think indirect taxes, is the way forward. And it's only how you carry out some critical planning, see which products or goods that you can actually bring into the tax brackets. And it's not that you want to punish, you make the tax so punishable that people cannot consume because we are talking about increasing prices. But at least based on the volume and what you see and improving compliance on the administration of that tax handle, we think we can still have a lot of income that will come through that source, which we can use to support interventions in health sector, especially to tackle outbreaks that will happen. So I think indirect taxes is the best way forward in managing a situation like this.
Thank you very much. Is the colleague from Burundi back? Yeah, I'll give you 2 minutes. I'll give you more time because you could not complete your intervention earlier on. Please do proceed.
Est-ce que vous m'écoutez? Vous m'entendez?
Yes, Oscar, please, we can hear you. Go ahead.
Merci,
Yes, we can,
merci.
Oscar.
Oui, merci beaucoup. Je m'excuse du problème technique. Je vais être très rapide pour commencer là où j'étais. Je parlais des initiatives et des stratégies déjà mises en place en cours d'opérationnalisation pour la promotion de le bien-être de la mère et de l'enfant. J'allais parler aussi des réformes de la gouvernance budgétaire qui sont en cours, tout en signalant que notre pays évolue progressivement vers un système de budgétisation axé sur les programmes qui relient mieux les allocations aux résultats. Et cette approche va nous permettre de gérer mieux avec transparence et efficience des ressources, y compris le secteur de la santé, avec un focus particulier sur la mère et l'enfant. Un autre jalon que je dois signaler, c'est l'élaboration régulière des comptes nationaux de la santé tous les 2 ans. Ces comptes nous donnent une vision claire des efforts financiers nationaux et des contributions extérieures et cela nous permet de réaligner nos priorités et de mieux nous orienter dans nos interventions. Enfin, nous bénéficions actuellement du soutien du Fonds de pandémie qui finance des projets de prévention, préparation et de réponse aux urgences de santé publique. Et ces investissements nous ont aidés à renforcer la surveillance des laboratoires et les capacités de riposte. Vous savez que le Burundi fait face à l'épidémie Mpox depuis juillet 2024. Nous avons pu la maîtriser grâce à l'appui de ces fonds, comme les fonds du pandémie et de la Banque mondiale. Et aujourd'hui, je dirais que le Mpox est sous contrôle et nous nous sommes très préparés pour les autres menaces du genre de santé publique. Et actuellement aussi, je dois signaler qu'avec ces fonds du pandémie, nous avons pu nous renforcer par rapport au centre des opérations d'urgence de santé publique et la mise en place d'un laboratoire national qui est dans la vision de l'approche One Health qui prend en compte la santé humaine, animale et environnementale. Tout cela pour nous permettre à mieux construire un système de santé qui soit plus résilient et face aux pandémies actuellement qui frappent à nos portes. Je dois me conclure par 3 messages écrits, par l'expérience que nous avons eue au Burundi grâce à la mobilisation des ressources extérieures et intérieures, et que cette mobilisation des ressources domestiques nous a aidés et nous aidera comme une pierre angulaire vers la souveraineté sanitaire. Et surtout que ce financement Catalytic comme ceux non seulement du Fonds mondial, du Pandemic Fund, mais aussi de la Banque mondiale. Je dois aussi parler du financement de l'Agence française de développement qui vont nous permettre de développer un projet du capital humain qui est conjoint entre le secteur de la santé et le système éducatif du Burundi. Et ces financements vont nous permettre de miser sur l'équité, mais aussi la résilience pour guider nos actions en accordant une priorité particulière aux plus vulnérables, notamment les femmes, les enfants et les adolescents. Donc, je dois finir par l'engagement ferme du Burundi à poursuivre ces réformes, mais surtout à renforcer les partenariats, surtout au niveau régional, en ce qui est de la surveillance et de la riposte efficace aux pandémies, mais aussi à travailler en synergie avec non seulement la communauté régionale, mais aussi la communauté internationale. Et je dois aussi faire un plaidoyer que dans cette dynamique, la diplomatie sanitaire et la coopération doivent jouer pleinement leur rôle de levier innovant pour atteindre les objectifs de notre pays, qui sont même les objectifs de la développement pour toute la région africaine et internationale. Je vous remercie.
Thank you very much, Dr. Oscar. Thanks for returning to the platform. Let's go to Rajat for your closing remarks.
Thank you. Thank you for that, Chair. I don't think there is a question that is addressed to me. So I just would like to make two very brief points. And that relates to the issue of innovative financing that both the country speakers mentioned too as well. And do deeply appreciate the value of taxes and blended financing and other issues that have been talked about. I did wanted to say the importance of ensuring intentionality and making sure that vulnerable population groups such as women and children's health is identified as a priority in those discussions. Importantly, of course, one understands that one cannot start earmarking resources by every disease, by every population group, and the focus and emphasis does and must go to primary health care. But the question is how those resources, what interventions are prioritized within these resource staff settings is important, because the direct impact that we are finding, whether it is in terms of pandemics or is it in terms of aid cuts on primary health care, is being borne by women and children the most. So with that passing remark, I wanted to say thank you very much for the opportunity to engage. Back to you.
Appreciated. Agri, your closing remarks?
No, thank you very much. I think I have nothing much to add. The call is out. I think we need all hands on deck to push the needle in the right direction. All of us from our different positions and capabilities have a role to play. And I think like my analogy, which I used in my opening remark, those of us who are exactly, putting fire from the top and those of us who are putting fire from below, I think we need to be consistent and determined and use this opportunity. I think it's an unfortunate moment, but it's an opportunity also to reflect and direct policy reforms in the right direction. Thank you.
Thank you very much. Before I give it to Linda to do a summary, and then she will hand over to Mark Pleasure, who will do a vote of thanks. I must remark that the challenge facing the university today, in light of this discussion, is that of designing and deploying dynamic curriculum which can produce a new cadre of a public policy graduate with the skills that enables them to work in various sectors. As you can see from this discussion, that you need someone who's very dynamic, multi and transdisciplinary trained, who can work in these various sectors and be able to manage public policy in a very complex and dynamic environment. the idea of training a public policy specialist who might just be narrow in their focus might bring challenges in terms of the ability of people to manage these type of complexities. And this is the challenge that the higher education is facing, and I think we should be able to respond to that. And you can only do that if we open frontiers of conversations and knowledge like these ones, because through this practitioner perspective that we have had from all of you today, we should be able to look at how we can have an impact, both on the research agenda, but most in particular in terms of the curriculum. And that is why the University of Johannesburg is playing a role in this program. Let me now hand over to my co-moderator, who will do a summary, and then we'll hand over to Mark Fletcher to do a vote of thanks. Thank you very much for your cooperation, colleagues. Are you there, Lynn? We cannot hear you, Linda. Mark, can you hear us?
Yes, I can hear you perfectly. I just can't hear Linda.
Please go ahead whilst we are sorting here out. Please, Mark, you can proceed. Good afternoon, and please do close the session.
Okay, so thank you very much, colleagues and honored guests. Just in closing the session from the point of view of the South Africa's presidency of the G20, we'd really like to thank the various speakers and countries which gave really excellent insights into the work you're doing, and to some degree the extent to which the work of the JHTF may have been useful to you. And we've appreciated hearing how within your countries you're attempting to do a wide range of interventions to look at fiscal space, but also on the synergies between ministries of health and finance, on transformative policies and progressive lawmaking for women and children and adolescent health, and the focus on DRM to finance the implementation of programs emanating from this work. Within our presidency in the G20, we very much wanted to health financing to be a critical paper, given the things that have happened in the world in this year. It's been such a strange world. The WHO really came to the party. They played a key role with partners in the bank, the OECD, African CDC, and many others in putting together the financing paper, which was very helpful to us. And obviously, calls a lot on DRM at this time of where we're struggling on donor funding commitments. In all of this, the role of strengthening Ministry of Finance, Ministry of Health collaboration is really important. So in the JHTF, it's been really important, in the G20, in your collaboration. But generally, we need to look at strengthening regional and global and national fora to increase this collaboration, because health departments cannot on their own solve the problem of DRM. It has to be a collaboration with finance. So progressively building these collaborations, and we are ourselves a bit concerned in the context of the JHTF with the incoming new presidency, how this may be affected. But noticing also the changing environment for donor funding in terms of the Lusaka agreement, which we all need to push harder on, but also the work emerging from CGD on interesting ideas about new forms of donor contracts. But we know that health financing is very low in Africa. I tried to respond to the colleague in the chat to say that IMF is really saying countries should try to at least get to 15% of GDP for tax revenue raised, and many of our countries are still below that. But I think all of us do need to hear this call that these vertical approaches, which have supported only infectious diseases or pandemics, are only one small part of the story, and increasingly looking at UHC, increasingly looking at the key areas of maternal and child health, which are absolutely central to increasing the populations, is key to our work. So we thank you, for your networks, collaboration, work, and wish you well for your future work, and really want to thank you for the excellent inputs today. Back to you, Chair.
I think you're muted.
Hear you. We can hear everybody else except for you.
Professor Busani, perhaps we will have you intervene on her behalf.
Yeah, okay. No, it's okay. So we coming to an end. This is a series, as it has been stated and it has been promised. It's a unique platform in the sense that you not just have one person to come and give a lecture, a typical masterclass arrangement, but of course you've got the people who are experts who work at national level, as well as people who work at a country level. Hopefully we will bring a lot more in future, including students. There are even public servants like the Mark Fletcher is responsible for managing the health budget in the National Treasury here in South Africa. We also have a colleague from Treasury in Sierra Leone. So it is a very unique platform in the sense that you can bring those very senior technocrats who work in this area. You can bring researchers, you can bring public servants, you can bring the academic community. Hopefully in future we'll bring other more civil society organizations. The work that is being done here is important. This is called the Global Leaders Network, which is leading this work. So it's not just something that is being done in the fringes of society or the fringes of public policy. So we'll be hosting a lot more of these in partnership with the National School of Government. We will also bring other partners in the APDIN network, which the National School of Government is a secretariat of. And the idea is to, as UJ being the start, is to bring a lot more universities into the space. So thank you very much once again for participating, those who are here and those who are online. This space is available for you. We can create a lot more of these interactions, and thank you for choosing the University of Johannesburg, or the Orange Army as it were, and thank to Dr. Manzi for coming in person, and everybody else in the Secretariat to be part of coordinating this webinar. Thank you very much, colleagues. Have a good afternoon further. Thank you.